INI-CET November 2022 discussion of recall question. So let us start discussing the questions which were asked in session 1 of your exam. There were a total of 6 questions, guys, which were asked, and they were equally distributed between various topics. As you will be able to see on the screen, 1 question each was asked from neuro-ophthalmology, glaucoma, conjunctiva, eyelids, cornea, and PSM related to ophthalmology. Out of the 6 questions, everybody, 2 were image-based, 1 from eyelids and 1 from cornea, as being indicated by orange line on the screen. So very equitable distribution of the topics. No topic was preferred per se. Yes. Let us move on to question number 1 and let us discuss it. Probably one of the easiest questions asked in session 1 in ophthalmology. So when we read the question, we need to focus on the word. Which of the following is true? Which of the following is true regarding optic neuritis? They have not asked true except. Yes. So which of the following is true regarding optic neuritis? Optic neuritis is a topic which all of us have studied regularly at various points of time. So should have been a very easy question. Let us see the options. RAPD, that is relative afferent pupillary defect, is seen. Is it seen? Yes or no? Yes, all of us know it is seen. It is the earliest sign. It is the earliest sign in cases of optic neuritis. Yes. Let us see option B. There is no pain on ocular movement. This is absolutely wrong. Yes or no? We know that there is pain on ocular movement. Yes. Number 3, multiple myeloma is a common cause. Multiple myeloma, no. We have always read MS. MS does not mean multiple myeloma, it is MM. So multiple sclerosis is the most common cause. And lastly, oral corticosteroids are the mainstay of treatment. Now we know that steroids are the treatment in cases of multiple sclerosis, optic neuritis is an inflammatory. But the word oral is what makes this option wrong. If we remember ONTT, optic neuritis treatment trial, we remember that oral steroids should not be given alone. They should always be IV followed by oral. Yes. So pretty easy question, as we would have been able to answer, I am hoping here, everybody. If we had answered it, we would have answered correctly. The answer is A. RAPD is seen in all cases of optic neuritis. Let's revise optic neuritis quickly, everybody. Let us move on to the clinical features of optic neuritis. In the clinical features of optic neuritis, let us remember this mnemonic. Do cup mar. 2C, 2U, 2P, MAR. Okay. Let's start with the top, everybody. C. C for what, everybody? C for the visual field defect. What do we see? Central scotoma. If you jog your memory a little, everybody, we have read in neuro-ophthalmology. What have we read? That all optic nerve diseases, the earliest visual field defect usually is central scotoma. Secondly, everybody, the patient has color blindness or loss of color vision. Which color vision is lost in optic nerve diseases? Again, neuro-ophthalmology, we have read this. Red-green. Okay. Instead of giving red-green color blindness, the option may be given by the examiner as dyschromatopsia. Again, we know this word, that color blindness is of 2 types, dyschromatopsia, achromatopsia, right? So we can use this word also. Then U, very important, everybody. U for unilateral. Unilateral loss of vision is the clinical feature of all cases of optic neuritis. Optic neuritis is never bilateral, everybody. So if it is written bilateral loss of vision in the question, then optic neuritis is ruled out then and there only. Yes. Then U, everybody, all of us have heard this Uthoff sign. Then P, everybody, Pulfrich or Pulfrich sign. Okay. Uthoff sign, Pulfrich sign. Uthoff sign is what, everybody? Uthoff sign is worsening of symptoms on production of body heat, body temperature. That is in cases of exercise. And Pulfrich sign, there is some problem in appreciation of kinetic objects. Yes. And then lastly, P, everybody, all of us know this. There is pain. Yes, there is pain on ocular movement. There is pain on ocular movement because there is a common sheath of the optic nerve and the extraocular muscles originating from the annulus of Zinn. That is why when optic nerve is inflamed on movement, there will be pain in the eye. Lastly, MAR, everybody. MAR is the fancy name, Marcus gun pupil, which is also known as all of us know RAPD, which we have already said, just writing it again, that it is the earliest sign. All right, everybody, are we clear about this? Are we clear about this, everybody? Yes. So these are the clinical features, everybody. 2, 2 cup mar. Then everybody, what are the types of optic neuritis? We remember that there are 3 types of optic neuritis. Number 1, retrobulbar neuritis. Retrobulbar neuritis, optic disc is absolutely appearing normal. Why is the optic disc appearing normal? Because retrobulbar neuritis is optic nerve inflammation, except optic disc. Yes or no? Retrobulbar, behind the eye. So optic disc is the first part of optic nerve which is in the eye. So optic disc is not inflamed. Everything else except optic disc is inflamed. Now, please remember, this is the most common presentation of optic neuritis usually seen in adults. Now we see the second photograph. In the second photograph, if we try to see carefully, we see that the margins of the optic disc are blurred. Can I say optic disc margins are hazy or blurred? If they are hazy or blurred, that means there is optic disc inflammation. Optic disc inflammation is known as papillitis. Okay. So it is absolutely opposite of retrobulbar neuritis. In retrobulbar neuritis, everything is getting inflamed except optic disc, whereas in papillitis, only optic disc is getting inflamed. Please remember, this is the most common type of optic neuritis in children. Neuroretinitis, third type, everybody. In neuroretinitis, the optic disc is inflamed as well as the macula is inflamed, and macula gets this peculiar appearance, as you will be able to see in this image, which is called the macular star appearance. Macular star appearance. Please remember, neuroretinitis is an important cause of macular star appearance. Now, once we know this, everybody, the types and the clinical features, what we should know is the treatment. Treatment, as I've already said, ONTT, optic neuritis treatment trial. What did optic neuritis treatment trial say? Optic neuritis treatment trial told us that what needs to be given? Intravenous methyl prednisolone 1 gram per day for 3 days, followed by oral prednisolone 1 mg per kg per day for 11 days. So this is what ONTT told us, that this should be the treatment regimen. Why only oral steroids are not given as option given in our question? Because we know that if we give only oral steroids, it increases the chances of recurrence. So oral steroids only are not the treatment. It is always IV followed by oral. Also, please remember, everybody, that the treatment on discuss here, the ONTT trial, it only hastens the recovery. That means it will fasten the recovery. Usually optic neuritis is self-resolving. The patient will get vision back by around 2 to 3 months. But if we need to fasten the recovery in around 2 weeks, then we need to institute this treatment. But it does not change, please remember, it does not change the final visual outcome. That means it is not going to improve the final visual outcome. The final visual outcome will be the same, whether you have given steroids or whether you did not give steroids. Only what you are doing is you are quickening the time that the patient is suffering. Am I making myself very clear here? Yes. And that's all about the treatment of optic neuritis. Lastly, please remember, everybody, it can be either typical optic neuritis or atypical optic neuritis. Typical optic neuritis, as defined by the McDonald's criteria in 2017, if all the clinical features and everything that we have just read, everybody, if all this is present along with MRI findings, blah, 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 then we say typical optic neuritis. If it is typical optic neuritis, then we know it can either be idiopathic, wherein we call it CIS, or it can be associated with multiple sclerosis, the most common cause or the most common association. But if it is not typical optic neuritis, if the answer is no, everybody, if it is lacking the clinical features, the characteristic typical clinical features along with the characteristic MRI lesions, everybody, then we say it is an atypical optic neuritis, and these disorders are known as neuromyelitis optica, or better known as NMOSD, neuromyelitis optica spectrum disorders. One of the examples, if you have read the lectures, I have told Devick's disease, everybody. This is one of the NMOSD group of diseases. This is a very rare group of disorders. But to diagnose this, we know that we will find two things, everybody: anti-MOG antibodies and anti-aquaporin 4 antibodies. So this is a question which you need to remember, that in cases of optic neuritis, you need to test for anti-aquaporin 4 as well as anti-MOG antibodies, because it may be a case of atypical optic neuritis also. So this is basically how we proceed towards the diagnosis of optic neuritis. All right, everybody. So we know the treatment, we know the grouping, everybody, we know the clinical features, we know the types, we know optic neuritis. And if I go back to the question, everybody, very quickly, which of the following is true? The answer is pretty clear. RAPD is seen. That's the correct answer. Now, let's move on to question number 2, everybody. The second question, everybody, was a repeat question. This was previously asked 1 year back also. Which of the following is the most common ocular manifestation? Okay. So out of COVID-19, there is only one question presumably which can be asked by the examiners, and that is why they are repeating it. Most common ocular manifestation. Now, all of us remember, I hope, that the most common ocular manifestation is conjunctivitis. That is where the examiners tried to throw in a trick. What do I mean to say they tried to throw in a trick? They gave two options, option B and option C, papillary conjunctivitis, follicular conjunctivitis. Now, if you had ever read the chapter conjunctiva or the topic conjunctivitis, you should not have had trouble whether you knew this as a fact or not. Why? We have read, everybody, pretty clearly bacterial conjunctivitis and allergic conjunctivitis. They lead to which kind of conjunctivitis? Papillae or papillary conjunctivitis. Whereas if it is chlamydial conjunctivitis or if it is viral conjunctivitis, both of these are follicular conjunctivitis. Yes or no? We remember this? If we remember this, we know COVID-19, we are talking about a virus, and the answer would have become pretty clear for us, everybody. What should have been the answer? The answer should have been follicular conjunctivitis. That is option C. Okay. If you don't remember the manifestations of COVID-19 in the eye, everybody, let us quickly revise them for you. Let us see, everybody, the ocular manifestations. The most common ocular manifestation is acute conjunctivitis. As I just now explained, it is which type of acute conjunctivitis, everybody? It is acute follicular conjunctivitis. Okay. This is usually seen in 2% to 32% of cases of COVID infections. Rare presentations, all these are rare presentations, everybody. Episcleritis, anterior scleritis, or anterior uveitis. Anterior uveitis is a part of MSID. MSID is multi-system inflammatory disease related or disorder related. Am I making myself very clear here? Now, the new question which can be asked in the future going forward from COVID-19 ophthalmic manifestations is this. This is a recent study which was done on RT-PCR positive newborns. What are the ocular manifestations of COVID-19 in newborns who have been proven RT-PCR positive? Here the answer changes. The most common answer no more remains conjunctivitis. As you can see on the screen, the most common now becomes what, everybody? The most common now becomes periorbital edema. In 100% cases of newborns, 15 children were there, or 15 newborns were there on which the study was done. All 15 had presented with periorbital edema upon birth. Then what also other features can be seen? Chemosis and hemorrhagic conjunctivitis. So conjunctivitis has to come back, but not at point 1, at point 2 rather. Then congestion. Obviously congestion again is a sign of conjunctivitis, and then corneal edema can also be seen. So please remember, take home, periorbital edema will be the most common manifestation in a newborn RT-PCR positive COVID-19. Are we clear about this? Let's move on to the question number 3. The third question which was asked in session 1, image-based question, as you can see, pretty easy question if you have ever read eyelids. Yes, I will say easy. This session 1 ophthalmology questions were easy. Does not mean session 2 were difficult, guys. Session 2, when we move on to session 2, were probably easier. Or no, I will not get into that comparison. Yes, I will not get into that debate that our questions were easier or not. From my point of view, both these sessions were pretty much the same, as I have already said. Yes. Now, identify the condition given in the image. Such an image was presented to you and you were asked the diagnosis. Whenever I get an image-based question, I would like to see that image and then speak what I can see in that image. So when I see this image, what can I see? Let me speak. I can see that there is some kind of fusion between lower lid and upper lid margins. Can I say this? As soon as I say fusion between lower lid and upper lid margin, I think ptosis goes out of the window. Ptosis is drooping of the upper eyelid. Yes, all of us know that. I think blepharospasm goes out of the window. Blepharospasm is spasm of the muscles. Then only two options ideally should have remained: ankyloblepharon or symblepharon. Now, if you know English, if you have ever read it, it should have been easy. What is the meaning of the word ankylo? Ankylo basically denotes fusion. What is the meaning of the word blephar? Blephar basically means eyelid margin. Yes. So ankyloblepharon, if we have ever read these, it means fusion of both the eyelid margins. And that is what the question was. That is what the answer needed to be. Very simple. The answer needed to be ankyloblepharon. Now, some students would have got confused with option A. Sound similar, these names. That is why I always tend to teach both these words together, ankyloblepharon and symblepharon. If you have any confusion, let us see the second image. What is this, everybody? What can you see in this image? Again, don't tell me the diagnosis. Describe the image. When I describe the image, what will I say? I will say there is adhesion, yes or no, between bulbar conjunctiva and palpebral conjunctiva. I hope we can see all these adhesive bands, everybody, going from the bulbar conjunctiva to the palpebral conjunctiva. So even though it looks like or feels like when we say symblepharon, a condition of the eyelid, everybody, is actually not related to eyelid. It is a manifestation in the conjunctiva, conjunctival pathology. So adhesion between bulbar conjunctiva and palpebral conjunctiva. And palpebral conjunctiva, known as symblepharon. All right, everybody. Now, let us go back to our image. Let us see the difference. No problem of the conjunctiva. This is a straight problem of the eyelid. Yes. Now, fusion of the eyelids, when we are discussing, it can either be a complete fusion or it can be a partial fusion. What do we see in this image? In this image, obviously, we see partial fusion, everybody. This is known as ankyloblepharon filiform adnatum. Okay, everybody, just a fancy name, ankyloblepharon for you. It is just partial. It could have been more. It could have been on the lateral side, the medial side, anywhere, everybody. I had the fortune, I can say fortune because I got to see such a case, everybody, some 7 or 8 months back. 28 days or 27 days old newborn had come to my clinic with ankyloblepharon filiform adnatum, and I had to treat it. The treatment is very simple, everybody. It is just kind of a tag, okay, which is connecting both the eyelids. So I kept my thumbs on lower eyelid and upper eyelid, and with a gentle force just pushed them apart, and the fusion broke away. And that's how simple the treatment is, okay. If it is more of a fusion, everybody, if it is fusion on the lateral side completely or on the medial side completely, everybody, obviously we have to go for reconstructive surgeries in the eyelid. Not going into the details of that, beyond our scope. Yes. Now, let us see ankyloblepharon in a little detail. Ankyloblepharon can either be congenital or it can be acquired. If it is congenital, it is usually due to non-separation of eyelid margins by 7th month of gestation. So the eyelid margins or the eyelids are formed at around the 4th month of gestation. And by the 7th month of gestation, everybody, these eyelids separate into the upper eyelid and the lower eyelid. If there is a failure to do so, everybody, you are born with ankyloblepharon, known as congenital ankyloblepharon. The most common associations, systemic associations of congenital ankyloblepharon can be remembered through this mnemonic, PERCH, that is perch. P for popliteal pterygium syndrome, E for Edwards syndrome, R for Rapp-Hodgkin syndrome, C for Chance syndrome, and H for Havel syndrome. Not very important as a question, but just to give you a completion of the topic, ankyloblepharon. Ankyloblepharon can also be acquired, everybody, acquired after birth. The most common cause is trauma. Yes, If there is a trauma, everybody, due to the traumatic injury to the eyelids, there can be fusion. Similarly, in case of burns, everybody, a burn injury, or in cases of disorders like Stevens-Johnson syndrome. Similarly, rare causes ulcerative blepharitis, ulcer on the blephar eyelid margin, or trachoma. Very important, trachoma can also lead to ankyloblepharon, because as we know, in trachoma there is cicatrization in the eyelid, everybody. Cicatrization leads to entropion, leads to trichiasis. So all these things can also lead to ankyloblepharon in rare cases. And tarsorrhaphy, that is surgical closure or surgical fusion of the upper and the lower eyelid, which may need to be done, let's say, in cases of Bell's palsy. In Bell's palsy, when there is paralysis of orbicularis oculi muscle, there is lag of ophthalmos. Even when the patient is sleeping, the eye does not close. There is exposure keratitis. So sometimes to protect the cornea or to protect the eye per se, we need to do tarsorrhaphy, everybody. So surgically, ankyloblepharon has been created. So this is a summary of your causes of ankyloblepharon, right? Now, let us see one more photograph to help us from any confusion in the future. When I see this newborn and I see the right eye, I think that there is some problem. Yes or no? Obviously, yes, I know there is some problem. I don't think that. Yes. Can we say the problem is ankyloblepharon? Can it be a complete ankyloblepharon? Complete fusion of upper and lower eyelid margin? Absolutely wrong. This is a different case. There is no formation of eyelids. Okay? There is no formation of eyelids. There is a complete skin which is covering all the ocular structures. You can't see any eyelashes. You can't see anything. This is not fusion of the eyelid margins. You can't see any eyelids at all. This is known as cryptophthalmos. Cryptophthalmos usually occurs in association with microphthalmia. Okay, usually found in cases of Fraser's syndrome. So I hope in the future, if such a photograph of cryptophthalmos comes, you don't confuse it with complete ankyloblepharon, right guys? And that's all about our question number 3. I hope you have been able to understand and remember the photograph that we have just shown you. Let's move on to the next question, question number 4. Again, an image-based question. One of the easy image-based questions, everybody, if you have even read a little bit of ophthalmology, that says, a farmer. As soon as I read farmer as an ophthalmologist, the first thing that comes into my mind is fungal corneal ulcer. Yes or no? Farmer means fungal corneal ulcer for me. Yes, let us read forward. A farmer presented with pain and discharge in his left eye. Okay. He says that he sustained injury with leaf. Okay, it is very clearly given. Fungal corneal ulcer has history of trauma with vegetative material. Yes or no? The classic line, I hope all of us remember. So if we remember this, this becomes very easy for us. Farmer, vegetative material, that means the case in the question is beyond any doubt fungal corneal ulcer. What is the finding seen in the image? All this for nothing, everybody. You don't need to know whether it is fungal corneal ulcer or not. This is just an image-based question. Yes, they have just asked you to diagnose the finding seen in the image. So what finding is seen in the image? Let us see, everybody. I can see 2 findings. One is this and one is all this, all this. So all this redness, everybody, that I can see, I will call it congestion, circumcorneal congestion, or I can call it fancily hyperemia. If I was a simple patient, I would have just called redness. Yes. But what is this, everybody? Number 2. This is some whitish collection in the anterior chamber. Yes or no? Is it anterior chamber? Yes, it is anterior chamber. So I know I should not be discussing this. This everybody knows. Yes, I know I am just wasting time. I know this is a case of, oh sorry, wrong color. But this is a case of what, everybody? Hypopyon. So that is the answer, everybody. Hypopyon. Yes. If you have not read hypopyon, then I think you need to go back and read ophthalmology. Yes, yes, I am being very blunt. If only you could have confused it with hyphema. So let us differentiate between both the conditions, hypopyon and hyphema. So what is hypopyon, everybody? Hypopyon is collection of pus in anterior chamber, whereas hyphema is collection of blood in anterior chamber. Yes, I hope we are pretty clear about this. Yes or no? Yes. If you have not seen a hypema photograph, let me show you a hypema photograph also. Let us see image A, everybody. In image A, what are we able to see, everybody? We are able to see this large area, everybody. We can see pupil only superiorly. We cannot see any iris tissue here. Dark brown or dark red color, everybody. Collection of blood. That means this is an image of hypema. What is the second image, everybody? See between the black lines that has been drawn, you can see a line of cicatrization in the upper lid. Line of cicatrization in the upper lid, everybody, is known as Art's line, seen in cases of trachoma. Trachoma is peculiar because it causes inflammation and cicatrization at the same time. So the active stage and the healing stage go together hand in hand. Hubbard pits are seen, follicles are seen, sago grain follicles. I hope you remember all that about trachoma. Yes, everybody, are we clear about this? Pretty simple. Let us revise fungal corneal ulcer through another image, everybody. So this is what a fungal corneal ulcer would look like. In the center, you will be able to see a large ulcer, everybody. This is a dry looking ulcer with feathery margins usually. Then you are able to see a faint ring between these pink arrows, everybody. You are able to see a faint ring surrounding the ulcer. Yes, this is the Wesley immune ring, the famous ring. Another important sign is satellite lesions, and another important sign is hypopyon, which was asked to us in the image, everybody, given to us in the question. Now, hypopyon is seen in both ulcers, bacterial corneal ulcer as well as fungal corneal ulcer. Very basic third prof knowledge. Bacterial and fungal corneal ulcer, how do you differentiate? So bacterial corneal ulcer is mobile. The pus is very thin. So with the movement of the head, it will move and it is sterile. Whereas a fungal hypopyon is immobile. It is thick pus and it, everybody, is asterile. Yes. I hope you remember these basics. Also, about fungal corneal ulcer, if I ask you what is the treatment, or I can say what is the drug of choice of fungal corneal ulcer, the answer should be natamycin eye drops. Natamycin eye drops, as the most common cause is a septate filamentous fungi, which is aspergillus. All right, everybody, please don't answer amphotericin B. Amphotericin B will only be given if it is a fungal corneal ulcer due to candida. Yes, are we pretty clear about this? Yes. Let us move on to the next question, everybody. Question number 5 asked in session number 1. All right. The commonest cause of moderate to severe visual impairment. So this is what was new in this. Moderate to severe visual impairment. They did not ask you most common cause of blindness. The most common cause of moderate to severe visual impairment, according to the National Survey report of 2015 to 19. I don't know this. Okay. I don't know what is National Survey report. I have never read this. If I wanted to take an educated guess about the most common cause of something which is causing loss of vision or visual impairment, out of the options, what would you have said? That's what I'm trying to say. Anywhere, wherever we have read ever, most common cause of loss of vision, gradual painless, most common cause of blindness in India, I hope we have always read one word only. What is that one word? Cataract. So if I had to take an educated guess, everybody, would I have answered cataract? Yes, I would have. I did not know it. Yes, I did not know it. It's all right. But again, you need to develop that art of how to solve questions which you don't know also based on whatever rudimentary knowledge you have. Yes. So the answer is untreated cataract. Now, if you don't know this survey report or this program, everybody, let us just discuss this quickly. So this was National Blindness and Visual Impairment Survey. Why blindness and visual impairment? Because I hope we remember now the name of the program has changed, everybody. What is the national program in India now called as, everybody? National Program for Control of Blindness and Visual Impairment. So no more are we talking about blindness. We are talking about blindness and visual impairment. Okay. So this survey was primarily done to find out the blindness causes in greater than 50 years of age. But it was done for other population also by a methodology which is called as RAB6 methodology. A future question, everybody. What is RAB6? Rapid Assessment of Avoidable Blindness. Rapid Assessment of Avoidable Blindness. Now, the estimated prevalence after this survey was done in the overall population for blindness was estimated to be 0.36%. Okay, overall population, not greater than 50%. Of severe visual impairment, 0.35%. Moderate visual impairment, 1.84%, whereas early visual impairment, 2.92%. That means now, whatever we are discussing, we will be discussing under 4 heads: blindness, severe and moderate visual impairment, and early visual impairment. Okay, everybody? This is a future question, I hope. Blindness, 0.36%. Why? Because according to the Vision 2020 program, the global target for reducing blindness was down to 0.3%. That means India has come very close to that, everybody. Yes. Earlier, there was the blindness load was calculated to be 1.1% in India according to the 2011-12 survey. So we have drastically been able to reduce the overall load of blindness in India. Now, causes of blindness and visual impairment in greater than 50 years. First of all, everybody, please read the top line. That is the most important line. Cataract is the principal cause of blindness, severe visual impairment, and moderate visual impairment. For all the categories, everybody, that we have seen, moderate visual impairment, severe visual impairment, and blindness, the answer is cataract, the most common cause. All right. So I can go back and I can say that for all the first 3 categories, the most common cause is cataract. Most common cause is cataract. I hope we're pretty clear about this. Yes. Now, let's move back, everybody. When I move back, everybody, the other important causes of blindness. So what is the second most common cause of blindness? Earlier it used to be refractory errors. Now it is corneal opacity. What is the third most common cause of blindness? Cataract surgical complications. Then posterior segment disorders excluding diabetic retinopathy and age-related macular degeneration, and finally glaucoma. All right, everybody. What are the principal causes of severe visual impairment other than cataract? Cataract is the most common. So the second most common cause of severe to moderate visual impairment is cataract surgical complications. Third most common cause, cataract surgical complications for blindness, and second most common cause for moderate to severe visual impairment. And the third most common cause for severe moderate visual impairment is posterior segment diseases excluding DR and ARMD. Okay, are we clear about this? So most common cataract, most common cataract. Second most common corneal opacity. Third most common cataract surgical complication. Fourth most common posterior segment diseases. Now this is for blindness. If I make the list, this is for moderate to severe visual impairment. Here second most common becomes cataract surgical complications. Third most common becomes posterior segment disorders. I hope we will be able to remember it. Number 1 remains number 1. Number 3 becomes number 2. Number 4 becomes number 3. Number 2 in blindness is corneal opacity. That is how we can remember, everybody. Yes. Now, the only new question or the different question apart from this will be, what is the most common for early visual impairment? So the most common for early visual impairment is refractive error. So all in all, what we are trying to say, that because of education, because of penetration of medical services throughout the rural areas of the country, refractory errors no more lead to blindness. They are detected at an early stage and they are treated then and there. That is why they are only a cause of early visual impairment, not moderate, not severe, not blindness. I hope we are pretty clear about this. Yes or no? So a lot of questions on this single page for you. Moving on, everybody. This was in greater than 50 years, everybody. But what about people age 0 to 49 years? In people age 0 to 49 years, we don't expect cataract to occur. Yes, obviously we don't. So the majority of cases of blindness in this age group were non-trachomatous corneal blindness. So the number 2 basically cause in greater than 50, that was corneal opacity, becomes the number 1 cause in less than 49 years because cataract usually does not occur in this group. Okay. The most important cause of visual impairment in this group was refractory error again. Okay, everybody. Then untreated cataract, then other things. So please remember, They are going to ask you either overall, whenever question is asked, please answer cataract. If they go into the categories of blindness or visual impairment or early visual impairment, please read the question carefully from all the information that I have just provided, and please try to answer carefully. And that's in short about your National Survey for Blindness and Visual Impairment done in 2015 to 2019 by AIMS in association with the Ministry of Health and Family Welfare using RAB6 methodology. Right. Now, let us move on to the next question, everybody. The last question which was asked in session 1. The following feature is not, that is the question. The following feature is not a feature of optic disc in glaucoma. They're simply asking you all of the features which can be seen in glaucoma as optic disc changes except. Yes? So as soon as I start reading, I read option A, Roni nasal step. I say, oh, Roni nasal step can be seen in glaucoma. Can it be? Yes. But Roni's nasal step, is it a optic disc change or is it a visual field defect? So I think I try to jog my memory and remember, and I say, oh, nasal step or step defects are a visual field defect. My answer becomes clear right here only. But just for the sake of reading, let me read the other options. Bayoneting sign seen, yes. Increase in CDR, yes. I know CDR becomes greater than 0.5 in cases of glaucoma. Bearing of nasal arteries, may or maybe I didn't know. Even if I didn't know, I know that the option A is correct. Yes. So we know all the three B, C, D are optic disc signs, but Roni's nasal step or step defects are visual field defects. Let us quickly revise the optic disc changes in glaucoma, everybody. Let us see each photograph one by one. Let us first see the photograph A on the screen. A is a normal optic disc. You will be able to see the optic disc margin. Within the center, you will be able to see optic cup. If I say roughly CDR is somewhere around 0.4, 0.3, normal. But then when I say image B, everybody, I see this is my optic disc, large optic cup. Optic cup, if I say roughly is around 0.8. So I know in image B, increased CDR, cup disc ratio is there. Increased CDR means I am looking at a glaucomatous optic disc. Yes or no? If there is increased CDR, that means the neuroretinal rim has been lost. So I can say NRR loss. Along with NRR loss, what can I say, everybody? I can say there the blood vessels have been pushed from the center to the periphery. So we call this nasalization of blood vessels. I hope you can see this. See the blood vessels in the normal optic disc starting from the center going out. Here there is no blood vessel in the center. All the blood vessels have been pushed to the nasal side. Along with that, you can see some faint vessels on the nasal edge of the optic cup. That is called as bearing of nasal. That is called as bearing of nasal blood vessels. So basically both of these are in conjunction with each other because nasalization is occurring. That is bearing. That is why bearing of nasal blood vessels is occurring. Okay. Now if I see image C, everybody, which is the sign I can see? I see this blood vessel. This blood vessel is coming in, dipping by 90 degree, again dipping by 90 degree. Yes, that means it is coming in, going 90 degree vertical, then going 90 degree horizontal. Double angulation of blood vessel known as bayoneting sign. All right, everybody, pretty clear, we know this. Let us see some other images, everybody. Let us see image D. In image D, between the two white arrows, between the two red lines, you can see a wedge-shaped area, everybody, which is shining with red color. So we call this RNFL, retinal nerve fiber layer wedge-shaped defects. This is usually seen on green-free filter. So in your slit lamp, you have a green-free filter. So when you shine light onto the fundus with a green-free filter, then you're able to appreciate that. Then lastly, in this photograph, what are we able to see? We are able to see two zones of atrophy surrounding the optic disc. Optic disc, everybody? Surrounding the optic disc, first of all, between these black lines, we see a whitish area. This is called as zone beta. Then outside zone beta, we see a blacker, darker area. This is called zone alpha. Zone beta and zone alpha both are types of or two zones of peripapillary atrophy. Atrophy around the optic disc. If we see zone beta, everybody, can I say zone beta is also known as temporal myopic crescent? Zone beta also known as temporal myopic crescent, everybody. Yes or no? That means zone beta is not specific to glaucoma. What is specific to glaucoma is zone alpha, everybody. Zone alpha is seen only in cases of glaucoma, whereas zone beta can be seen in cases of myopia, also which we already know, area of peripapillary atrophy. These are the important signs, everybody, of the optic disc. Now let us see the important visual field effects. Let us quickly revise. Paracentral scotoma. Around the center, a scotoma is there. Then this joins the optic disc blind spot known as scotoma, sickle-shaped scotoma. Then it travels nasally, does not affect the center, affects all the arcuate fibers, the superior arcuate fibers and the inferior arcuate fibers. What are superior arcuate fibers? Fibers going from the optic disc over the macula. Yes or no? Arcuate visual field effect, also known as B-Yerum scotoma. Then it becomes superior and inferior both double arcuate. When double arcuate occurs, then we need to pay attention, everybody. The superior field is more lost than the inferior field. It looks as if due to the unequal loss of visual fields in the superior and inferior hemisphere, a staircase has been formed or a step has been formed. Step defects, and a nasal defect is known as Roney's step defect. I hope we remember this. I hope we comprehend this. After Roney's nasal step defect, everybody, what occurs? Central visual loss. But central visual loss is not the last, everybody. The last to be lost is temporal vision. I hope we remember these simple facts about glaucoma, everybody. Last to be lost, everybody. Yes, and that's your quick lowdown on this simple question. The last question that was asked in session 1 of INI-CET November 2022. As you would have seen, I hope, everybody, all these questions were pretty simple, pretty direct. If you had read ophthalmology even decently, you should have been able to solve all the questions. Now we'll start with the session 2 questions. So let's start with the session 2 questions now, everybody. Session 2 questions, there were 8 questions from ophthalmology. So you may say 6 in session 1, 8 in session 2. Is it unfair? No, it is not unfair. As you will see, session 8, even though it had more questions, but some of the questions were actually not pure ophthalmology. They were ophthalmologic pharmacology. So you could have actually considered them pharmacology questions. But for the sake of complete discussion here, we are including it here. Apart from that, you will find again an equitable distribution. One question from neuro-ophthalmology, one from conjunctiva, one from cornea, one from lens, one from retina, one from optics, one from glaucoma per se, and 2 pharmacologic questions from glaucoma. Yes, so in total 8 questions were asked. Session 2 questions kind of gave you a glimpse into what your next exam, if and when it comes, may be like. So there were questions related to ophthalmic medicine. There were questions related to ophthalmic physiology, ophthalmic pharmacology. So that is what next is supposed to be. A topic or a subject rather, ophthalmology and its related sciences. So next will not be more difficult if and when it comes. Again and again I'm saying if and when it comes. I don't know when it will come. Please don't ask me when it is going to come. I am as clueless as you are, guys. Yes, all I know is it will be more basic. They will appeal more to your base sciences. You can never ignore your base sciences. That's all. Yes. Let us start discussing the first question that was asked, everybody. Oculocephalic reflex assesses which of the following nerves? So this is basically an ICU thing, everybody. Yes, oculocephalic reflex. If you don't, or if you're not familiar with this name, let me write another name. Doll's eye reflex, everybody. Okay. So oculocephalic reflex, OCR, or Doll's eye reflexes assesses which of the following nerves. It was a multiple correct option, everybody. The options were 3rd nerve, 4th nerve, 6th, 8th, and 7th, and multiple options were given. So before answering this, let us understand what is Doll's eye reflex or oculocephalic reflex if we don't know this, everybody. Okay. So the patient's eyes are held open by the examiners, and then the patient moves the head of the patient from left side to right side. Okay, everybody. So why eyes kept open? Because I want to see the ocular movements, obviously, everybody. Then on brisk movement from right side to left side, everybody, yes, If you try to see, I will do it slowly for you, everybody. When I move right, my eyes move left to maintain straight fixation. When I move left, my eyes move right to maintain straight fixation. Yes, that is what our tendency is. Brisk movement. I'm just showing it to you slowly. Yes. So it looks as if I have doll's eyes. A scary doll eyes. You may move the doll from left to right, but the eyes keep looking straight, everybody. Yes, this is oculocephalic reflex, or known as, everybody, doll's eye reflex. What does it indicate? If the eyes rotate to opposite side, everybody, if the eyes rotate to opposite side, that means they remain straight. When I move right head, eyes left straight, that means the brain stem is intact, everybody. Yes, the same test can be done by tilting the head back and forward also, but most commonly done from side to side. That is how you elicit the doll's eye reflex. Please remember, this should not be done if there has been a cervical spine injury. This is contraindicated in a patient who has some kind of problem in the cervical spine. Now, what does a doll's eye reflex tell us, or what are its uses, everybody? It can be used to find out vestibular lesions where you have disorientation problems because your body cannot find the position. It can be used to assess dizziness. It can be used in psychiatric patients, everybody. Or most commonly, as I said, it is used in ICU, in critically ill patients to detect the altered mental status. Lastly, it can also be used in neonates because neonates exhibit an unsuppressed doll's eye reflex before 11.5 weeks, and thus it serves as a milestone, everybody. Okay, so these are certain uses. Now, if I go back, everybody, brain stem lesion, the nerves which are present in the brain stem. So what is the oculocephalic reflex assessing, everybody? Third nerve, sixth nerve, and eighth nerve. Yes. So the answer is A, C, and D. Vestibular lesions, eighth nerve, sixth nerve, left, right, everybody, lateral rectus, third nerve, medial rectus, the extraocular muscles, everybody. So that is what the answer is. Oculocephalic reflex or doll's eye reflex assesses third nerve, sixth nerve, and eighth nerve. Now, let us move on forward to the second question, everybody. The second question was a pretty straightforward question from ophthalmology, should have been very easy for all of us to solve. Which of the following is not a part? That is the key word to remember here. Which of the following is not a part of keratoconus? So straight question on keratoconus was asked. Once we read the options, it became pretty easy. Irregular astigmatism. Do I know it? I don't know. Munson signs, yes, it is found in keratoconus. Habs-Stry, no. I know Habs-Stry are found in what, everybody? Habs-Stry are found in congenital glaucoma. Do I know this? Yes. Scissoring reflex, yes. Scissoring reflex as seen on retinoscopy. So I am pretty clear. Habs-Stry is a characteristic feature of congenital glaucoma. So Habs-Stry are not seen in cases of keratoconus, and that is the answer. Let us see what are the other features. Scissoring reflex, just like that, there is another reflex, everybody, if you remember, oil droplet reflex. Do we remember this, everybody? Yes, I hope. Oil droplet reflex as seen on ophthalmoscopy. Yes, very good, guys. Okay. So let us see some photographs now to quickly revise keratoconus, everybody. Cone-shaped cornea. On torchlight external examination, what can we see? On torchlight external examination, we can see two signs. What is this, everybody? Yes, this is Munson sign. What is Munson sign? When you look down, there is V-shaped bulging of the lower eyelid. Then, everybody, second photograph. I hope you have seen it. I hope. Yes. This is known as Rizzuto's sign. What is Rizzuto's sign? When light is thrown from the temporal side, everybody, on the nasal limbus, we see an arrowhead of light being formed. This is Rizzuto's sign. Both these are external findings because I can find them on torchlight. Now, everybody, slit lamp findings. Slit lamp finding, photograph C. In photograph C, if I see the cornea carefully, what can I see? I just zoom this out for you. Can we see some scratch marks? Can we see some striae? Can we? Habs-Stry. But Habs-Stry, we have just said, are seen in congenital glaucoma. Is it that Habs-Stry may also be seen in keratoconus? No. Yes. Which striae are these, everybody? Vogt striae. Striae are seen, but they are not Habs-Stry. They are called as Vogt striae. Pretty good, everybody. Now, D, everybody. You will be able to see blue illumination or cobalt blue light, everybody, shining onto the cornea. What are we able to see? Peculiar photograph. Very rarely, difficult to see, but if we try to see, we are able to see. Between the arrows I draw 360 degree, you will be able to see a faint brown colored ring. I hope. Surrounding the center, pericentral, paracentral. Can you see this? I'll just draw another arrow inside also. Don't say the pupil. I'm not talking about the pupil here, everybody. Okay. Can you see this faint brown ring between my arrows, all my arrows, everybody? Yes. This is what ring, everybody? This is, I hope we remember, Flesher's ring, not Kayser-Flesher's ring. Flesher's ring, due to deposition of what, everybody? Due to deposition of iron or hemosiderin. Yes. Yes, everybody. Yes. Okay, everybody. So this is what a Flesher's ring looks like. Now, everybody, E. What are we able to see? Can you see the thickness of the corneal slit here in the periphery versus in the center? Can you see it is thinner in the center? So we say paracentral thinning and steepening. Paracentral thinning and steepening. Obviously, that is keratoconus for us. Yes. Apart from this, we already know scissoring and oil droplet reflex. These are some of the important signs seen in keratoconus. Now, if we remember a recent question which was asked on this photograph, what is this, everybody? This is a photograph of a procedure called as INTACs. What is INTACs, everybody? Intracorneal stromal rings. Yes. So two semicircular rings covering around 160 degree each are inserted within the stroma in the periphery, everybody. You can see the same ring first, you can read the second ring. Why are they inserted, everybody? Because these rings, they will stretch the periphery of the cornea. When they're stretching the periphery of the cornea, in effect, they are flattening the curvature of the cornea. The INTACs are used as a treatment in keratoconus. Yes. But they can also be used as a treatment for very high myopia. I hope you remember this, everybody, about INTACs. That's all about quick revision about keratoconus. Let's move on to the third question, which was asked from ophthalmology, everybody, in session 2. Again, a very easy question on a very easy topic. Which of the following is not a feature of pterygium? So pterygium is per se a very common topic asked by the examiners, everybody. Topics like pterygium, corneal ulcer, retinoblastoma, cataract. These are famous topics of repetitively asked questions, everybody. Yes. So whenever you read ophthalmology, please focus on repeatedly asked topics. Please try and make a list of the topics which have been asked in the past 5 to 10 years so that you're able to pay more focus on them. Yes. Now, which of the following is not? Again, the question is not a feature of pterygium. So let me just read the options as if it am an exam and let us try to see whether I can solve this question. Elastotic degeneration of stromal collagen. Do I know this? I don't know. Question mark. I'm not sure. The parts are head, neck and body. Yes, this I have read. Yes, this I have read. This everybody knows. So pterygium has 3 parts: head, neck and body. Okay. Simple excision reduces 95% recurrence. Am I? This looks wrong. Why does this look wrong? I'm thinking as I'm reading it. Because we have been taught that the treatment is pterygium excision, but then to reduce the recurrence, either we use mitomycin C drops or we do autografting. If simple excision reduces 95% recurrence, almost all cases recurrence is not occurring, then why would have I needed mitomycin C? Why would have I needed autografting? I must not have been doing autografting and mitomycin C just to reduce 5% chances of recurrence. So I think that this data is wrong. Yes, that is my thinking, because I know pterygium excision, only excision leads to high chances of recurrence, almost 80% chances of recurrence. 80% recurrence will occur. And that is why to reduce recurrence, I have to do something else. And that is how I would have solved this question. Which of the following is not a feature of pterygium? Last option, again, I am unsure of. Progressive and regressive type. If I have read it in detail, I know there are 2 types, progressive and regressive. So let us see, everybody, what is progressive, what is regressive. Not a very common classification of pterygium per se, but progressive pterygium is said to be fleshy and more vascular in appearance, whereas a regressive pterygium, everybody, is said to be more fibrotic and avascular. So basically, we are saying regressive. Regressive is not basically literally meaning that the pterygium is itself coming away. Regressive is basically saying that it is not going to progress more. There is no blood supply anymore. So it is become inactive more or less, everybody. So again, I am saying this is something which you should have known, but even if you didn't know, you could have solved this question. Regressive type, everybody, is usually associated with Stocker's line. I hope you remember Stocker's line. Iron deposition. Yes, iron deposition in front of the pterygium head, and that is usually seen in chronic cases or in regressive type. Now, let us see a photograph, everybody. I hope you remember this. We can clearly see this is the head. At the limbus, over the limbus, this is the neck, and then this is my body. Okay, everybody. So this is what a triangular growth of conjunctival degeneration over the cornea, destroying its superficial stroma and Bowman's membrane looks like. Can pterygium lead to loss of vision? Yes. Loss of vision can either be due to astigmatism, or it can be due to blockage of visual axis. Yes. So in this case, because the pupil is pretty clear right now, the loss of vision will be due to astigmatism. But if the pterygium grows big, everybody, it also covers the center of the pupil, then it is due to blockage of visual axis. The treatment I have already discussed with you is not simple excision. We excise, then we take an autograft and we autograft it. Why is autografting required? Because pterygium usually we read occurs due to heat dust, which is wrong. It occurs due to limbal stem cell deficiency. So when we are autografting, in effect, we are transplanting the limbal stem cells from one side to the pterygial side. Pterygium usually occurs in the nasal side. Okay, everybody. So we take a graft usually from the supratemporal side and we transplant the limbal cells along with the graft onto the excised part of the pterygium. I hope we are pretty clear about this. I hope all of us understand this. And this is a very easy question on pterygium. Moving on to the fourth question, everybody, which was asked, the simplest question in session 2, the simplest point blank, 10 seconds. Which of the following is not a feature of complicated cataract? Complicated cataract is a cataract which occurs due to Umar, yes, or Ramu. U for uveitis occurs after uveitis, yes, everybody. M for myopia, A for angle closure glaucoma, R for retinitis pigmentosa. We know this. One option is correct. Okay. Then what is the presentation? The presentation is breadcrumb appearance with polychromatic luster. What is the site of complicated cataract? Most commonly it is posterior subcapsular. These are the only 8 points or 7 points that we teach in complicated cataract. So point number 1, UMAR, polychromatic luster, breadcrumb appearance and posterior subcapsular. 7 points in total, out of which 3 are asked. Krukenberg spindle. This is the answer to the question, everybody. Krukenberg spindle is seen in? Krukenberg spindle is seen in? Anybody? Krukenberg spindle is seen in? Yes, very good. Krukenberg spindle is seen in pigmentary dispersion syndrome, or I can say pigmentary glaucoma. It is seen in pigmentary dispersion syndrome or pigmentary glaucoma. Deposition of pigments on corneal endothelium. All right, everybody, that is Krukenberg spindle. I hope we remember a little bit of pigmentary dispersion syndrome. It leads to secondary open angle glaucoma. It is more common in myopes who are young and who are Males, everybody, Krukenberg spindle is seen, Sampolicy line is seen, Zentamere line is seen. So all the clinical features of pigment dispersion syndrome, out of that Krukenberg spindle was given as an option in this question. The easiest question, everybody. Let us move on to the next question, everybody. Atropine is contraindicated in which of the following conditions? Again, if you did not use too much of your brain, if you did not complicate it for yourself, it would have been a 1 second question. But a lot of students love to complicate. So let us complicate. Complicate means I don't want to answer it straight away. I know atropine is contraindicated in acute congestive glaucoma. I know, but I am doubtful. So let me rule out. Let's say how I rule out. Acute anterior uveitis, also known as iridocyclitis. Yes. Do I use atropine in this? Yes. What is the treatment? The treatment is steroids, topical steroids, okay. Plus along with that, cycloplegics. Cycloplegics, atropine is a cycloplegic, yes or no? Why do we use cycloplegics in anterior uveitis? Because it relaxes ciliary spasm, okay. And what was the second use, everybody? Second use was it prevents formation of posterior synechiae. This is pretty clearly written everywhere. This we have read. So this should not have been a confusion at all. Atropine is used in acute anterior uveitis. We are sure it is not contraindicated. Corneal ulcer. Corneal ulcer. Corneal ulcer, the treatment is antibiotics if we are talking about bacterial corneal ulcer. But along with that, we have always been taught supportive therapy is atropine. Yes. Why supportive therapy atropine? Because in every case of bacterial or fungal infection, everybody, the toxins can irritate the ciliary muscle, can lead to ciliary spasm and thus to pain. So again, here also atropine relaxes ciliary spasm and thus reduces the pain. I know this, I have read this very clearly. Then, because I am supposed to overuse my brain, I will say malignant glaucoma. Oh, this looks like a fancy name. This must be the answer. That is what we do as students. We like to overthink when we are unsure. Even if you are unsure, please go with your gut feeling. Your gut feeling would have said acute congestive glaucoma because you have read it. In primary angle closure glaucoma, acute congestive glaucoma, atropine is contraindicated. The drug of choice is pilocarpine. Atropine is contraindicated. The patient gives history of pain when he goes into a cinema hall. So cinema hall should not be gone to because the pupil is dilated. Dilatation should not occur. All these things have been taught to you. They have been spoken. You have heard them. You just needed to remember them and not complicate it. But let's say whether you complicated it or not, malignant glaucoma. Malignant glaucoma is also known as aqueous misdirection syndrome. Why is it known as aqueous misdirection syndrome? Because aqueous flows from posterior chamber posteriorly due to ciliolenticular block. Ciliolenticular block means the equator of the lens and the ciliary processes touch each other. The equator of the lens and the ciliary processes touch each other. So because they touch each other, the aqueous cannot flow anteriorly. The aqueous flows or it has pressure posteriorly. Aqueous misdirection syndrome. Due to this, what occurs, everybody? Angle closure glaucoma. The other name for this is inverse glaucoma. Why? Because in angle closure glaucoma, the drug given should have been, pilocarpine. But here, what is the treatment? Atropine. Why atropine? Because atropine breaks the ciliolenticular block. Atropine will dilate the pupil, will stretch the iris and the ciliary muscle backwards. It will stretch it backwards. When it stretches it backwards or outwards, I can say, it will break the ciliolenticular block. Malignant glaucoma also known as aqueous misdirection syndrome, also known as inverse glaucoma. Yes, are we pretty clear about this? So atropine is contraindicated in angle closure glaucoma or acute congestive glaucoma. Now, if you need to know why, very simple explanation. In angle closure glaucoma, primary angle closure glaucoma, rough diagram, guys. This is what is occurring. Yes or no? There is pressure here. Yes. Yes or no, everybody? The pupillary margin touches the anterior surface of the lens. There is pupillary block. That is why the pressure in the posterior chamber pushes the iris forward, leading to angle closure. If I dilate the pupil, the angle which is already closed, the iris tissue bunches up everybody into the angle, further complicating the issue. So I need pilocarpine to pull the iris tissue from the angle and not atropine to fill the angle with iris tissue. I hope we are able to understand this. Yes. So the simple answer is atropine is contraindicated in acute congestive glaucoma. Yes. Let us move on to the next question, everybody. Match the following. Okay, this 3 was a match the following, though it was a very easy match the following. Color vision. Color vision is by Ishihara chart. We know that. All right. So this was pretty easy. Color vision by Ishihara chart. IOP. IOP by applanation tonometry. Again, pretty easy, I hope. Now the confusion came. Peripheral vision, central vision. We know perimetry, but we have never heard the name tangent screen test. So now perimetry is for peripheral vision or central vision. That was the confusion. That is where this question became difficult. So think about it. Perimetry. Through perimetry, do you only see the foveal vision? Don't you see the peripheral vision? Don't you see arcuate visual field effects? Don't you see that? We say central visual field is lost at the last in perimetry. We have seen perimetry. Perimetry, we get a visual field graph or plotting like this. Yes or no? That means perimetry can be used for peripheral visual field also. If I used my common sense. If I use my common sense, then this would have been the answer. And central vision by tangent screen test. That is what was new to us in this. We had never heard the name tangent screen test. Not a very commonly done test. It's almost a rudimentary test, everybody. But nonetheless, it was used as part of your match the following. So I will just give you a little brief about it. So if I am talking about visual field examination, visual field examination, it can be done by perimetry or it can be done by something called as campimetry. Perimetry can be used to measure the central plus the peripheral field. Campimetry is only for central visual field. The basic difference between both of them is in terms of the equipment. Perimetry uses bowl type curved screens, whereas campimetry uses non-curved, or I can simply say flat screens. In terms of the equipment, if we are talking about. All right, everybody? Yes. So all of know perimetry in detail. We have seen kinetic perimetry, static perimetry. Yes or no? I hope we remember all this. Yes. Kinetic perimetry, static perimetry, Humphrey's field analyzer. Let us think what is campimetry. Campimetry is done by tangent screen test. Tangent screen test, in short, is this black screen, a flat screen on which grid lines are drawn. Okay. Then the examiner will pick up this black stick. Over this black stick, they will place any of these red or blue colored targets. They will slowly bring this, let's say this is my stick, everybody, and I have a red target here. I will slowly bring this from the periphery into the visual. Obviously, one eye will be closed. Slowly bring this from the periphery into the visual field of the patient. At whichever point the patient says, I can see, at that point, you will mark it onto the graph. Okay. So you will do it in all the quadrants, you will get the visual field. That is the simplest way of doing visual field testing. But this can only be used for central visual field charting. Peripheral visual field charting cannot be done through this. You can vary the size of the target to find out the visual field capacity also in terms of the intensity of vision also in this. All right, everybody, that is basically simple tangent screen test. It is not clinically used anymore. Now, moving on to the next question, everybody. This was a repeat question, albeit a simpler question. Angle subtended by each optotype. Angle subtended by each optotype for 6 by 6 vision on Snellen's chart at 6 meters. The language of this question is not correct. This is the language that we have got to know told to us by remembering. All in all, the essence of this question was that it was asked if the patient is standing at 6 meters and reading the line for 6 by 6 vision. Okay, what is the angle subtended? So I think this was a pretty easy question because we know the principle of Snellen's chart. What is the principle of Snellen's chart? I will just write it down for you. Each optotype or each letter subtends an angle of, everybody, subtends an angle of, yes, 5 minutes. Subtends an angle of 5 minutes of arc at nodal point of eye when viewed from its respective distance. Yes or no? So, for the line for 6 by 6 vision, the respective distance is 6, the patient is at 6. So, obviously the answer had to be 5 minutes of arc. All right, everybody. In previous years, everybody, the question which was asked was, the angle subtended by the optotype for 6 by 6 vision when the patient is standing at what meter, everybody? 60 meter. Okay. So, in such cases, the formula is, everybody, given distance by respective distance into 5. So, if the patient is standing at 60 meters, into 5 is equal to 50 minutes. Okay, I hope we are pretty clear about this. Yes or no? No confusion? Now, let us see, everybody. Each optotype is constructed in such a way that it has 5 strokes. Stroke 1, stroke 2, stroke 3, stroke 4, stroke 5. The width of each line of the letter is made in such a way that this will form an angle of 1 minute of arc on the patient's eye or on the observer's eye, such that when you accumulate it, the total angle becomes 5 minutes of arc. Why is that so? Because we know the minimum angle of resolution, MAR, of the human eye is around 60 seconds. So if we know if these 2 points, the angle is less than 1 minute of arc, then the patient may not be able to differentiate between these points and the vision will become blurry. So that is the principle on which Snellen's chart testing works. So repeat question, we have discussed this. I hope this should have been a very easy question coming into your exam. Now, moving on to the next question, everybody. This is ocular physiology question. Photoreceptors act by. So photoreceptors are peculiar if we have ever read, everybody, because almost all the neural impulses act by depolarization. But photoreceptors are peculiar because they act by hyperpolarization and not depolarization. Okay. So let us see, everybody. Phototransduction. After light has fallen onto the retina, everybody, light has been absorbed by the rhodopsin pigment. It will activate. Activated rhodopsin is known as metarhodopsin 2. This activated rhodopsin, which is present in the outer segment of the rod cells or the cone cells for that matter, that is the photoreceptors, this sets in a cascade. Activated rhodopsin activates the transduction via the GTP-GDP exchange. This GTP-GDP exchange, everybody, leads to activation of phosphodiesterase enzyme, which catalyzes the conversion of cyclic GMP to 5-GMP. So when this is catalyzed, From cyclic GMP to 5 GMP upon light falling, everybody, cyclic GMP levels will reduce. When cyclic GMP levels reduce, everybody, they close the sodium channels and the calcium channels. Thus, the sodium coming in and the calcium coming in reduce. So, CGMP levels are decreased, the sodium channels and the calcium channels are closed, and this leads to a hyperpolarizing potential set into the photoreceptors. Okay, everybody, that is how photoreceptors act. Please remember, this hyperpolarizing potential generated due to decreased CGMP levels in the rod cells and the cone cells. This is not an action potential. This is a graded potential, graded change in membrane potential, which is conducted to bipolar cells, then conducted to ganglion cells, and action potential is actually produced. AP is produced in ganglion cells. So because the distance of conduction is very small from photoreceptors to bipolar cells to ganglion cells, we don't need action potential. What is there, everybody? Graded membrane potential, GMP, graded membrane potential. Then from ganglion cells, the impulse needs to travel in optic nerve, large distance, everybody. That is what is generated, or that is why what is generated, everybody? Action potential. So photoreceptors generate potential by hyperpolarization. Hyperpolarization is occurring due to CGMP. Decreased sodium channels are closed. Am I making myself very correct? But this potential is graded potential. Action potential will be produced in ganglion cells. To summarize, everybody, let's see. In dark conditions, we have depolarization. Whereas in light conditions, we have hyperpolarization. Okay. Now, in depolarized condition, because my CGMP levels are high, my open sodium and calcium channels are high. So that is why plus is coming inside the rod cell, and that is why the membrane potential is less negative. But in light conditions, as we just now saw, because of activation of phosphodiesterase enzyme, the CGMP levels are low, due to which the calcium and sodium channels are closed or decreased. That is why sodium and calcium are not able to flow inside. So when they are not able to flow inside, the plus sign is not coming inside. So the negativity is increasing. So the membrane potential in light conditions during photoreceptor action becomes minus 65 millivolt, everybody. So this is your summary of photoreceptors. How do they act? And then through graded membrane potential, how do they convey or transmit the impulse generated? So once we know all this, everybody, I hope we can pretty clearly answer this as hyperpolarization via decrease in neurotransmitter. Am I making myself very clear? So this was the option photoreceptors act by. Okay, everybody, ocular physiology. Now, let us move on to the next question here, everybody. So the next question is a simple pharmacology question on a new drug per se. Which of the following drugs act by increasing the trabecular outflow? Now, the answer should have been pretty clear. Nitarsudil, it has been taught to you. But there were a lot of students who came back to me saying, sir, we marked brimonidine. Now, why did you mark brimonidine? Because, sir, it has been taught to us. No, it has not been taught to you. At least not by me. I have said alpha agonists are 2, apraclonidine, brimonidine. Apraclonidine decreases the aqueous production. Plus, it is postulated to increase a little bit of trabecular outflow. And brimonidine only decreases the aqueous production. Clearly taught, clearly written in notes, everybody. Why brimonidine came into the question, I have no idea. It has always been said that apraclonidine, brimonidine, even though they are both alpha agonists, both have slightly different mechanism of actions and different ocular side effects also. Yes? So let us summarize, everybody. Which are the drugs which increase uveoscleral outflow? So uveoscleral outflow can be increased, or is increased rather, mainly by the prostaglandin analogs, latanoprost. It can also be increased by the alpha agonists. If we are talking about alpha agonists, we are talking about brimonidine. Now, decreased aqueous production, all the groups, everybody. Beta blockers, yes. Carbonic anhydrase, yes. Alpha agonists, both alpha agonists. And even nitarsodil. But then we come to the important group. What group increases the trabecular outflow? So alpha agonists, but only which alpha agonist? Only apraclonidine or nitarsodil. Okay, everybody? Even if both the options would have been given in the question, they are not been given. Even if both would have been given, what would have been the better answer, everybody? Nitarsodil, everybody. Nitarsodil has come into being just because of this fact, because the traditional drugs that we use, they primarily decrease the aqueous production. Latanoprost or prostaglandin analogs became the drug of choice because they started increasing uveoscleral outflow. And that is why the excitement around nitarsodil, because it increases the trabecular outflow. So let us everybody see a little bit about nitarsodil. Nitarsodil, first of all, what is the dosage of nitarsodil, everybody? So the dosage of nitarsodil is 0.02% given OD. Please remember, nitarsodil is FDA approved. Then, what is its use? Its use is in primary open angle glaucoma. It is also very helpful in steroid induced glaucoma. And even reports have come that it is useful in normal tension glaucoma. Okay. Now, mechanism of action. Very simple. Nitarsodil gets converted into its active metabolite, which is called nitarsodil M1. Nitarsodil M1 has two mechanisms of action. Number one, it is a NET inhibitor. NET inhibitor means it is a norepinephrine transport inhibitor. Norepinephrine transport inhibitor decreases the aqueous production by decreasing the adrenergic transmission. Transport is blocked, so adrenergic transmission is blocked, so aqueous production is blocked. All right, everybody, or reduced. Then ROCK inhibitor. What is ROCK inhibitor? Rho kinase. ROCK, everybody. Rho kinase inhibitor. Rho kinase inhibitor. What does it do, everybody? Rho kinase inhibitor increases the trabecular outflow by reducing assembly of actin fibers in the trabecular meshwork. So Rho kinase is responsible for assembly of actin fibers, everybody. So when assembly of actin fibers is reduced, everybody, when the focal adhesions are broken between the trabecular meshwork, everybody, what will occur? The trabecular meshwork, the mesh will slightly enlarge, the holes will become slightly enlarged because the structure is not getting formed at thicker, and thus the trabecular outflow will increase. This is one of the important mechanisms of action. Trabecular outflow is increased. Okay, are we clear? Now, also remember, everybody, what are the adverse effects? The most common adverse effect is hyperemia. Hyperemia or congestion, or I can simply say redness. Second important is subconjunctival hemorrhage. And thirdly, it causes vortex keratopathy or cornea verticillata. Please remember these. Why? Because examiners love to ask side effects, ocular side effects or adverse effects of anti-glaucoma drugs. Very common question. So if you want to ask me one question which will always be asked in every exam is anti-glaucoma drugs. Yes, it will always be asked. Anti-glaucoma drugs, cornea, conjunctiva, cataract, pterygium, corneal ulcer. All these topics are very commonly asked. Retina, one question. Neuro-ophthalmology, one question. They are very common. So ophthalmology, you have to read completely in order to be able to answer all questions. And that is the beauty in ophthalmology. It is a high scoring subject. Even though it looks treacherous, even though we ignore it, we don't read it too much. But once you start to love it, you will actually end up loving it. Just like I did. I started loving ophthalmology in third year. Yes, it is rare, but I did. And when I did post-graduation, I fell in love with it. I started to enjoy it more. And the more I enjoyed it, the more I wanted to excel in it. And that is the key to study, everybody. The more you study, the more you enjoy, and the more you want to excel, everybody. It is a kick. Education or knowledge can also give you a kick. Enjoy studying. The more you enjoy studying, the more you will want to study, the more you will be able to succeed. Keep studying, keep solving MCQs. In any doubt, please feel free to get back to us. You can get back to me either on Instagram or on Facebook. Thank you, guys.